good afternoon, everyone. I would like to show my 6 months progress towards my PhD on implant placement, loading, and soft tissue management in the aesthetic zone. I'm currently a second-year resident at the Department of Prosthodontics, and my mission is to implement the best implant-prosthodontic treatment for the anterior region into everyday practice. And for this purpose, we started 3 projects, investigating different interventions around the single maxillary anterior implants. 2 are meta-analyses, and 1 is a clinical trial. In my first project, we investigate the effect of different placement and loading protocols. Altogether, according to the newest guideline, there are 12 types of implant placement and loading timings, indicated with a number and letter combination. The numbers will always indicate the timing of implant placement into the alveolar bone, while the letters indicate the timing of prosthetic rehabilitation on this implant. And the increasing numbers and letters mean the later this rehabilitation happens. Conventionally, the type 4C, or late placement and late loading, was followed, but understandably patients preferred the restoration of anterior teeth as soon as possible, and also the buccal bone is thinner and resorbs faster here, that make immediate treatments become more favored. Unfortunately, the current literature does not rank these procedures in terms of hard and soft tissue outcomes, so we would like to investigate that, and we would like to compare all of the protocols within a network meta-analysis. Our primary outcomes will be implant survival and marginal bone losses, while secondary outcomes will be soft tissue parameters and aesthetics. We included altogether 28 articles, and I have received all of my results. But due to the shortness of time, I will only be showing you the 5-year marginal bone losses, which unfortunately is the only long-term follow-up analysis we could make. And I will also show you the pink aesthetic scores, because in the anterior region, aesthetics is crucial. Unfortunately, we have a very weak network for the 5-year marginal bone losses, with only 10 pairwise comparisons. And our rankings show that the 4C and 4A protocols are the best treatments with a minimal difference. And you can see the same here on the league plot, showing mean differences with 95% confidence interval in millimeters. And the 1-year and 2-year plots show similar results, but we only have 1 mathematically significant difference here at 5 years between the 4A and 1A protocol. Unfortunately, you can see that the confidence interval is quite wide, touching the 0 effect. So clinically, we could not compare many protocols, so we can only say that the immediate placement does not perform as good as the late placement. For the pink aesthetic scores, we could compare 21 comparisons. And here we can see that loading has a larger effect. You can see that the 1A and 4A protocols perform best in terms of aesthetics, so immediate loading has the best effect. Unfortunately, we do not have any significant differences here. Weak evidence and weak network are unfortunately our limitations, and we did not have any data to analyze several protocols, nor could we analyze any long-term soft tissue and aesthetic results. However, our strengths that are, this is the one and only network meta-analysis so far in this topic, and this allowed us to analyze several protocols that the conventional method of meta-analysis cannot analyze. And we also made analysis for soft tissue and aesthetics, as well as 5-year marginal bone losses. Despite the weak evidence, we can still conclude that the 4C and 4A protocols, that is late placement, is the best in terms of bone preservation in medium long term. Therefore, it is the most predictable treatment option in the clinic. Whereas the immediate treatment, that is the 1A protocol, performed best in terms of soft tissue preservation and aesthetic results. Unfortunately, due to the lack of long-term follow-up, we have to apply it in the clinical practice with care. And it is an implication for research that we really need more randomized controlled trials with long-term follow-up for stronger evidence. I am currently writing my manuscript, and we hope to submit it by the end of April. Moving on to my second project, we would like to compare the effects of using CAD/CAM versus conventional healing abutments. After the implantation, the soft tissue needs to heal around the transmucosal abutment, and it will take a shape of that abutment. And our aim is to have an anatomically shaped soft tissue, so-called emergence profile in the end. However, the conventionally used stock healing abutments do not allow that because it is very narrow and non-anatomical. Therefore, the patient will have to go through lengthy and painful procedures in order to receive the final anatomical shape. And the new technology of computer-aided design and manufacturing, shortly CAD/CAM, allows us to fabricate individualized healing abutments or provisional crowns, which are very commonly used in the anterior region. And it allows a one-step formation of the anatomical emergence profile. However, it is only achievable with a pre-surgical backward planning, so it requires much more effort from the dentist. So we would like to compare these two types of healing abutments regarding their marginal bone losses, soft tissue parameters, aesthetics, as well as patient-reported outcomes. And we hypothesize that using individual CAD/CAM healing abutments will give better clinical results. Currently, we're at the phase of selection with this topic, and my third project is closely related to the second one, because here we would like to investigate the accuracy of using digital versus conventional impression methods in capturing this well-formed soft tissue emergence profile. As I've mentioned, in the anterior region, most commonly provisional restoration is used for this formation. And for the long-term success and aesthetic results, it is crucial that we copy as accurately as possible the shape of this restoration onto the final restoration. And the gold standard method of doing so is taking a conventional impression with individualized impression coping, as you can see on the picture, and a conventional gypsum model can be poured from it. For the digital pathway, we have two options. We can either directly scan the emergence profile, but during that time there may be some soft tissue collapse that causes inaccuracy in the scanning. The other option is that we scan the provisional outside the mouth and then superimpose these scans with intraoral scans, which is why it's also called a multi-scan technique. And from this we can obtain a 3D printed model. Our aims are to compare the accuracy of these two types of digital impressions, as well as the 3D printed model obtained from this, to the conventional gold standard method. And we would also like to measure the amount of mucosal collapse in case of the direct scanning and see how it changes with time around maxillary single anterior implants in patients with thick gingival phenotype. And here you can see some further selection criteria of our patients. And we would like to include altogether 15 patients in our study. In a nutshell, we would start with the in vivo part of our study, where the patient will receive in order the direct scanning, indirect scanning, and the conventional impression method. And after obtaining the models from these methods, we can continue the in vitro part of comparing the models. We have received a faculty research grant to support our studies, and its only requirement is that we submit our publication this year, so we are working very hard on our 3 projects, and if all goes well, then we will be able to submit them this year. And I would like to thank your kind attention with a quote on the Greek poet Hesiod: "But before the road of excellence, the immortal gods have placed sweat." Thank you.
Regarding your first project, are patients underwent sinus lift or osteoplasty? They were excluded, or they are included?
Thank you for the question. Since we are talking about only the premaxillar area between the second premolar to the other side second premolar, so the sinus is not really a factor here.
Okay, thank you.
My question is whether a comment or not, but I haven't ever seen any before, after, and 2 years after pictures. Have you seen ever those kind of aesthetical results pictures?
Unfortunately, they rarely have such long follow-ups.
That's before, after, but yes. I haven't seen any picture 2 years after. Yeah, that's true, unfortunately. Okay, so the recommendation is, which one is more beneficial from your point of view? The immediate loading because of the aesthetical result, or the delayed loading and the late treatment? So what is the overall suggestion to the clinicians?
So we have an international guideline from the Straumann ITI group from 2018, but they do not give strong recommendations. However, the same authors that give this guideline wrote a systematic review in 2021, where they analyzed the survival rates of these, but only the survival rates of these implants in several regions, separately in the mouth. And for the maxillary anterior region, they suggested that the type 1C and 4A options are scientifically and clinically validated.